good afternoon, everybody. My name is Mohammed Iqbal. I'm one of the neurosurgeons here at Dell Children here in Austin. Thank you all so much for coming all this way to attend this conference. As my slides get up. What I'm tasked to talk about today are the surgical techniques in epilepsy, specifically the tailored approaches to hemispherectomies. Now, in recent years, now we've started to ask the question, which of the variety of hemispherectomies that exist are going to give us the best outcomes, and these are challenging surgeries. No relevant disclosures. So the objective of this talk will be to describe the different indications for hemispherectomy. We'll go over the difference in naming. We'll understand the evolution of the surgical management of hemispheric epilepsy, identify the pros and cons as well as risk and benefits of the different surgical approaches for hemispherectomies, and we'll identify the risk factors that are associated with the outcomes for these different approaches. The objective of a hemispherectomy is something that's not a surprise to any of us here in this audience, and that is to improve seizure control. And ideally, it's cure of seizures with cessation of all medications. Epilepsy is the most prevalent chronic neurological condition in children, affecting 1 in 150 children in the first 10 years of life. With a hemispherectomy, we can get 62 to 80% long-term seizure freedom. So, it's a very effective operation for the right patients. We want to improve developmental outcome. This is something specific to us here in the pediatric population, and 35% of children with epilepsy are refractory, with persistent seizures that disrupt their cognitive development and ultimately quality of life. So hemispheric epilepsy comes in 3 general categories, and I think this is a nice conceptual way to think about it, but later in the talk we'll see how perhaps this should be restructured in terms of understanding prognosis. So there's the developmental category, which includes the hemimegalencephalies, polymicrogyrias, chronic cortical dysplasia. These are the ones that can lead to catastrophic epilepsy. Catastrophic epilepsy is epilepsy that starts so young that it gets in the way of total development and you have very delayed children. So this is why it belongs to the developmental category, because the seizures usually start younger. There's the acquired, which are things that, as the name implies, have come after birth, or within like a perinatal stroke, which would have happened sometime around gestation, head trauma, CNS infection. And then there's the progressive conditions, the Rasmussen encephalitis, the Sturge-Weber syndromes. Here on the image, we'll see on the first, there's a hemimegalencephaly. To the right of that is a perinatal infarct, and the bottom image there is one of my own Rasmussen's patients recently treated. So the evolution of the hemispherectomy. Now, it started with an anatomic hemispherectomy that was done for tumor by Walter Dandy in 1928. That was the first written about. Then the first one done for seizure on a child was by Dr. McKenzie in 1938. The first series published on medically refractory epilepsy and anatomic hemispherectomies was published in the 50s by Corewell. The functional hemispherectomy was developed in the 70s by Rasmussen in response to the complications they were finding after doing the hemispherectomy surgery for the 20 years preceding it, in response to superficial hemosiderosis, and we'll go over some of those things. Further modifications with less brain resection were developed in the 90s. The term hemispherectomy came when Dell talked about his vertical hemispherectomy approach in 1992. Now, I learned a lot of my epilepsy in the UK to start, and they used the word hemispherectomy, so that's my chosen language. But hemispherectomy itself was meant to denote less brain resection. But even in Dell approach, there is a corticotomy that's involved. There is an amount of brain that is removed. So here's just a graphic and a visual of and an MRI of an anatomic hemispherectomy. So typically what's left is the thalamus and sometimes the insula, but also it's been done with taking the thalamus out altogether. On the image here is one of our own patients of Dr. Talakabara, which was a completion hemispherectomy in a patient who had residual seizures following hemispherectomy approaches. Now, why we went to a less invasive option or a less resective option was superficial cerebral hemosiderosis, which is an inflammatory reaction in the meninges, hemosiderin particles in the macrophages, ependymitis and hydrocephalus with microscopic subpupillar necrotic lesions. This was seen in 2 patients in a German study back in the 50s, and this is how we, based on autopsy. So they thought this was the reason that people were having hydrocephalus as high as 50%, or neurological disability. The mortality rates were 30 to 40% beyond 4 years, all the way up to 24 years later after surgery, as reported in the Rasmussen series. And, I thought this was kind of nice that came out of Rasmussen's paper. It's just like a surgeon. It says, in 1968, we abandoned the technically gratifying and therapeutically effective operation of complete one-stage hemispherectomy in 83 because of all the above statistics. So here's a nice image of Rasmussen's approach in response to the full anatomic resection. It was a temporal lobe resection, a frontal and parietal opercular window, where you took out a portion of the frontal lobe, parietal lobe, gave you access to the corpus callosum, midbrain structures. You did a corpus callosotomy and a frontal fiber disconnection, and the frontal lobe and the occipital lobes were left in place. So now you went from having this giant cavity on one side of your head to 2 decent-sized lobes that are still remaining with the disconnection that proved to be still effective. Now, this is another really nice image to show the different approaches, to hemispheric disconnection. The first you see is a total anatomic hemispherectomy, which did include removing the thalamus. Now, just a word on removing the thalamus. There was a paper that came out by the French group that looked at post-hemispherectomy and hemispherotomy reorganization, functional reorganization that's done a year, 2 years later. And they found that there isn't really a lot happening in the remaining part of the brain that's even in the thalamus that's left behind, but it did have a little bit of activity. So removing the thalamus in the past and still having decent outcomes is not a complete surprise to me based on that more modern study. So the functional hemispherectomy you see there is what was described in that last slide, which is removing the temporal lobe, removing the operculum, and now giving you better access to the corpus callosum. Then came the peri-insular hemispherectomy, and you can see on the bottom row of images that on the sagittal, the cortical window is much smaller. It's just the operculum now that can be removed. Now, there is a variety of ways to do this. You can still remove the temporal lobe and do this opercular window and still call it a peri-insular hemispherotomy. And then Schramm's transfylvian hemispherectomy, which is minimally resective. You just go through the sylvian fissure and you go about disconnecting the different fibers, and we'll go over what they are. All of them have the same ultimate anatomic goal of disconnection. And then there's the vertical hemispherectomy, which comes from the top down. And again, in the graphic there, you can see it will access the corpus callosum. It'll access the perithalamic white matter in the thalamus. It'll get you to the frontal lobe to get the frontal fiber disconnection. It'll get you into the atrium so you can see the limbic structures and do a limbic disconnection. It gives you the access to all these places. Now, here's a table that was made, and for some reason the 4th row is gone. But the 4 basic disconnections that are achieved by all of these approaches, or are hoped to achieve by all these approaches, is the callosotomy, right? What we use surgically to help us know that we're getting the corpus callosum is really the pericallosal arteries, the anterior cerebral artery. Whether you do it from the top down, looking in the interhemispheric fissure, you're staring at the artery as you're disconnecting the corpus callosum, or if you come laterally and you come from inside the ventricle and then come up, and then now you're looking at the pericallosals from the inside out. Either way, that's the anatomic structure that we're using as surgeons to complete and follow the callosotomy. Then there's the posterior lateral disconnection. This is really the insular, or all things connected to the thalamus disconnection. And this landmark that's used to do that here is from a vertical approach, and that is when you come from the top down into the lateral ventricle, you're staring down at the choroid plexus and the foramen of Monroe. Posteriorly, you're going into the atrium. That choroid plexus, if you just go right lateral to it at the caudate and beyond, and just keep disconnecting in white matter, you're really getting right in between that insula and the basal ganglia, ideally, and then you're getting your disconnection of all things thalamus. And then the anterior disconnection, if you go all the way to the bottom of your corpus callosum in the front, the rostrum, you'll find the anterior cerebral artery as it and you'll see brain there, frontal lobe, you resect that. You follow that out on the middle cerebral artery until you get to the sphenoid ridge, into the sylvian fissure, and then now you've done your whole horizontal fiber disconnection, anterior commissure, anterior limb with internal capsule. And the final disconnection is a limbic disconnection, because that's still attached after these three. To do that, you remove the amygdala in the vertical approach, so that way you can get rid of the outstream from the stria terminalis connection. And then posteriorly, you get rid of the crus of the fornix, and that gives you both sides of the limbic system, no longer making any communication across. So the modern era of hemispherectomy, there's a million different approaches that have been talked about, whether it's with visualization with a camera endoscopically, or hemidecortication, where you're moving just sort of the cortical surface. But today, really the two approaches that people use are either a lateral approach or a vertical approach. And we're talking about coming from the side or coming from the top down. Coming from the side is performed along the axis of the sylvian fissure. This was championed by Villemure and Schramm. The vertical approach is performed along the axis of the inner hemispheric fissure. Whether you go through the fissure or you go just lateral to it and take some of that frontal lobe out to get to the corpus callosum. And this was championed initially by Delalande, Chandra with his endoscope, Dr. Lamb as well, who's among us, Blome, I never say his name correctly, but he's the chief at Necker in France, and they've done a ton of work on this. And here are just some MRI images of not exactly hemispherectomy. Some of them are posterior quadrant disconnections, but it just shows you an MRI of really what it looks like, in column B, for example, when you go from the top down, disconnecting just lateral to the thalamus and getting the corpus callosum. And then when you look at the axial, you can see it's very thalamic in its disconnection. So the real meat of this talk is about, which one is better. How do we pick which approach is good for this patient? And in the last since 2021, this topic has been approached head on. First by Dr. Fowler's group with the HOPS study, and what they looked at was 600 patients in the lateral group, 72 patients in the vertical group across multi-center collaboration, and what they found was that the vertical group had better seizure freedom, and it took longer for them to get to their first seizure after surgery. So, it was regarded as, hey, look, vertical is better than lateral. We should all start doing that. There are a lot of criticisms, and this is the main table that comes from that, at least in who their patients are. And the criticisms that sort of come from this paper is that, it's very unbalanced. The vertical group is 72 patients. The lateral group is 600 patients. Their long-term follow-up where they start to diverge is really at 6 years, but they only have 100 patients that get beyond 5 years in their follow-up. So really, which patient population are you basing your conclusions on? They report no MRI findings of the people that were residually connected or failed their hemispherectomy, and they don't talk about complications at all, right? So how can you make a conclusion about what's a better surgery if you don't know how dangerous one is over the other? So then came the European study that came just 2 years after that, and they looked at, and the other criticism of that paper was that those patients included all the way back to the 1970s, and the technical approach, has changed over time. Much more of those were, technically lateral before, so perhaps the vertical, which is more newer and modern, may have better outcomes when you compare to older approaches. This paper came from a series of European institutions, and they covered from 2000 to 2016, and they looked at their vertical versus lateral approaches. And here it's a little more balanced. You have 300 patients, 290 of them were in one group of lateral, and the vertical was 177. And what they found actually was that the etiology was more important, whether there was contralateral MRI findings, whether they had a prior surgery, which approached significance, didn't get significant, and the site of surgery. That determined the outcome. So when I was talking about the three categories of acquired, progressive, and developmental, here what they found is that other acquired, so the infections, the traumas, those have bad outcomes. So you can't say that all acquireds, because their perinatal strokes, are going to have great outcomes. That's what we want to think. is that stroke patients have great outcomes, but they're standing on their own with acquired as a category. Progressives do poorly, the developmental, but hemimegalencephaly specifically. Hemimegalencephaly, we all know for those that treat this surgically, this is a resistant, this has more likely to have recurrence. Why? And that may be because other developmental lesions have somatic mutations, but there may be a higher load of mosaicism in hemimegalencephaly, which may denote contralateral lesions, in that condition. So perhaps that's why this particular developmental disease is more likely to fail a hemispheric disconnection. The finding of contralateral MRI findings. What is a contralateral MRI finding? Is it a small T2 white matter signal? Is it some sulcal aberration? They didn't consider these things that I've just mentioned as MRI findings, something that was more significant. If you had that on the contralateral hemisphere, that was more likely to cause failure. Side of hemispherotomy, they showed that left was worse than right. The conjecture on that was, if you do, in younger children under the age of 2 or 3, maybe they were more aggressive about doing a left-sided approach because they thought language was going to develop on the right side. So they picked worse patients, and that may be why the left sides did worse than the right sides. I'm not sure I completely agree with that, but that's how they at least note it in their paper. So, ultimate and importantly, lateral versus vertical made no difference. The follow-up paper by Follow's group was a meta-analysis with individual patient data looked at specifically. So they really try to treat each patient in these different studies as their own patient when they did the meta-analysis. And here they still found a difference between lateral and vertical approaches. Here you had more balanced sort of numbers, you had longer-term follow-up, you had more, and you had complication report in this paper. So they try to really address the main criticisms that came from their post-hoc analysis. But the criticisms here are still that most of these vertical patients came from one center. They came from Dell Children Center, in France. So, these lateral patients came from a bunch of smaller centers, so that don't have as much experience. So are you really comparing the same? Are you doing the comparison justice? I don't think so. In that way, the approaches to the insula from the lateral approach are so varied. For example, do you resect the insula? Do you do a peri-insular undercut? Do you leave it? These things have all been done, for lateral approaches, and surely that plays a huge role in the outcome of your epilepsy. So I think that also can make a difference on your outcomes here that they see, the lateral versus the vertical. So what's the conclusion? I think there's still a lot to learn, about the specific factors that predict success of hemispherotomy. Ultimately, it's going to be probably the proficiency, of the technique that you do. If you do it well, then that's going to be more important than which one it is that you perform. There are more adaptations of technique to come, less invasive, equally disconnective. I'll just say from my own personal experience, I learned the lateral approach and doing it with the parasylvian, with the insular undercut. But as an attending, and still as a junior attending, I decided to do the vertical for my first patient because I thought it was going to be easier. I thought, based on all my reading and what I've been hearing from my mentors, that getting in from the top down just makes more anatomic sense. It is more challenging to get the amygdala out. That's the part to it that we have to always remember, not to leave it under the fold. But I did it, and it all went well. And just as a personal testament, I think that it can be done. I think it's an easier approach, but the studies, I think, have not really claimed that one is better than the other, despite the two papers. So the ultimate is, which one to do. I think do the one you do best, and be willing to try something else if it's not working. And I want to leave on that.
Can we have all of our speakers back up? We have a few minutes for questions and answers. It should be a 20-ish. Do we have any questions for our speakers?
Elizabeth, can I ask a question?
Of course.
Yeah. So my question is for Dr. Curry. Dr. Curry, this every now and then, I was looking at your slide, so every now and then you run into these patients who are in like 15, 16, 17 years old. They made it to you, and turns out that lifelong they had these gelastic seizures, and they have a kind of plum-sized hypothalamic hematoma. So your approach to the kid who's 15, 16 years, would it be a little bit different? How would you approach that, and what are the more risks for, especially if it's a girl?
I don't think I would approach it all that differently, but I would, counsel the patient that we're probably going to need a number of sessions, not just, laser blading of the lesion, but it's likely by 15 they're going to have some level of secondary epilepsy that may burn out over time or may not, and that's the sort of warning we need to give to the patient and the family that this may be just one step in a long journey of a surgical treatment of the seizures.
So I have a question, and I'm going to direct this to Omar. You talked about the wide variety of options and really the wide variety of reasons why we do hemispherectomies. I think one of the things that you didn't really touch on is sort of taking a look at that initial anatomy and looking at, because the post-stroke patient who's already got most of it, maybe the best thing to do is to just go do a completion hemispherectomy because it's already gone. How do you sort of make that decision about whether or not you're going to go for one of these more minimal approaches, or sort of how does the existing anatomy help you make a decision about what you're going to do?
So, the studies, first of all, haven't shown that there's a difference for the different. I mean, except for like, for example, that European paper didn't show that it didn't matter what your disease was. Whether it was an ischemic disease that gave you big ventricles, or whether it was a hemimegalencephaly. Well, the hemimegalencephaly made that. It still didn't matter what your approach was, vertical or lateral. What sort of conventionally people think about is if you have an ischemic condition, perinatal infarct, you have huge ventricles. So it should be an easier operation to do however you do it, whether you do it vertically, whether you do it laterally. The hemimegalencephaly may be easier to do vertically because the anatomy is a little bit more conserved as you kind of go into the ventricle and you can see everything. But and the anatomic hemispherectomy isn't better than doing a disconnection. So I think if you can do something less disruptive than a completion, even if it is a perinatal stroke, it's a better way to go. But ultimately, the literature has not shown that it matters.
Can I comment on that for a minute? Over the years, I've realized that hemimegalencephaly is kind of a different animal surgically. And when you get into the ventricle, I like to do the lateral approach, so you see all the white matter tracts and cut them. In hemimegalencephaly, there's so much infiltration of the gray into the white that getting a very clear cut and knowing where you are is very confusing. And so I've gone to anatomics up front on hemimegs. I don't know how many surgeons in the room have done that, but I just got sick of the recurrences. And to tell you the truth, they're doing okay. I mean, if they're really young, they have a very asymmetric skull shape, et cetera. But I haven't had a ton of hydrocephalus or hemosiderosis and all those other complications that drove the mastery of the disconnective approach.
Yeah.
And in that particular rare condition, I think it's worth trying.
Makes sense. We had a question here.
Thank you very much for the talks. So I don't have a big question, as Dan has a big push to be here, but I have a small question from Dr. Malik. When you do the MAGs, do you do the language lateralization too? And if you do, how is it matches with your fMRI results?
Yeah, we do language lateralization. How it matches with functional MRI, I think it varies from institute to institute. Pretty much, I would say 50 to 60% of the time I can lateralize receptive language, and even less percentage for the expressive language. But I think you have to keep in mind that MAG mostly is lateralization, not localization. like the localization would be hard if if your focus is close to your language area and you're trying to find out where the language is. That's a little bit asking too much kind of a thing. For lateralization, if it's left hemispheric, that's at least 50-60% of the time patients who get the awake mag, they are able to cooperate. So we do use it. Almost every patient not every, but we do it on a lot of patients, and we try to map it. But how successful you are, that I would say it's just a rough number. I'm not quoting any studies, but 50-60% of the time, you can confidently tell it's left hemispheric or not. Basically, lateralization, it's good for. Localization, I don't think MAG or any other modality, other than maybe TMS, probably can do a better job. But the functional imaging, fMRI or MAG scan, it's more for lateralization.
Mark?
Great. This Omar wanted to, great talk, by the way, and welcome to Texas. I'm very happy that you're at Dell, and I'm down in San Antonio, so anyway. A couple things. One, with the anatomic hemispherectomies, I've always noticed that when surgeons stop doing them because of the superficial hemosiderosis and the complications, that kind of coincided with before we started using shunts, the early 60s. And, to Dan's point, would it still be an okay operation now that we have shunts? Because I think it's like, the same thing as someone having chronic subdurals and hydrocephalus and that sort of thing.
Yeah, Peacock was the first one to write a paper that said we should shunt with our hemispherectomy, anatomic hemispherectomy at UCLA. He's like, this is the answer. We're having this bad complication. But I think ultimately and I can't think offhand what it was that, despite the hydrocephalus, other than the hydrocephalus, that still led to more neurologic disability, perhaps, with an anatomic hemispherectomy over the more disconnective approaches.
Then one other question, Rasmussen's encephalitis. So I haven't seen it in a while, but when I evolved from functional hemispherectomy to hemispherotomy, I was still operating on a few of those. And I don't know, for some reason I would always go with functional hemispherectomy because we don't really know the etiology. Do we need to remove more tissue? I don't know. So do you have an opinion on that?
No, I can just speak to what these papers have shown, and that it doesn't matter which approach you do for the Rasmussens, whether it's hemispherectomy, whether it's doing the hemispherotomy.
Okay. Yeah, and I would tend to operate on them pretty early in their disease state, after biopsy and proven Rasmussen's of a lesion. Mm-hmm. So they still had pretty robust hemispheres, but I can understand with the sort of burned out Rasmussen's, hemispherotomy would be very good. Mm-hmm. Thanks.
Yeah, thank you.
Dan?
Yeah, thanks. Great talks. Two quick questions, hopefully. In images, I often see the insula attached to the basal ganglia to very variable degree. Some centers completely resect the insula with every hemispherotomy, any type. And what % of peds epilepsy surgeons right now are removing 100% of the insula routinely? Do you know? Any idea?
I'm having a tough time calling up the paper, but somebody did a survey a number of years ago, and I remember, I think the number I recall was somewhere around 30%, 30 to 40% of the centers said by survey they would take the insula. It seemed lower than half, which was kind of amazing to me. I was always trained to do it.
Right. Yeah, it's the second most common failure reason, I think. But thank you. Second question is, are we moving toward endoscopic hemispherotomy for everyone in the future, or are we? I have no idea. And if we do that, can you remove the insula completely?
Well, I think it's important to understand what is endoscopic hemispherotomy achieving. What it was meant to do is just make a smaller bone opening. It's still, like in Chandra's approach, it's still, you go interhemispheric, you put the camera in and you're staring at the corpus callosum, but then you're using your standard microsurgical instruments to do the rest of the operation. So if you can still have a small bone opening and do that very same approach without an endoscope, I don't know that it's necessary. Now, that's what I understand about endoscopic hemispherectomy, but I think there are adaptations.
I would turf it to Sandy.
Yeah.
Sandy?
I'd actually go back to, Omar, your slide where you actually talk about the anatomy of what needs to happen on the inside for any hemispherectomy. So no matter how we call it, lateral, vertical, endoscopic, laser, some people, Chandra's now gone to poking like 110 times for 110 different trajectories to affect the same disconnections, or microscope or anything. It boils down actually to 4 disconnective anatomic things that you have to do, right? Corpus callosotomy, disconnecting the corona radiata fibers, frontobasal disconnection, and the limbic disconnection, you call it, right? Or the mesial temporal disconnection. You have to do all those 4 things no matter what instrument you use, right? So I would say, leave it up to the surgeon and really the surgeon experience and comfort and access to be able to achieve all those 4 disconnections. And no matter what, as a team, don't compromise on those disconnections. And kind of leave the instrument and the other stuff to really kind of the context appropriate or kind of place just all of the other factors that are intrinsic to the team, right? There are volume outcome relationships. And so I'd say whatever you do, whatever works for you, and you can see it and you can do the disconnections, go for it. And anatomic hemispherectomy really allows for you to see all of the things, right? Like, you take it all out. So if you're not used to using an endoscope and you can't see the stuff that you need to see, don't do it. But if you can, awesome, right? And that's from lateral or vertical. So that's actually how I boil it down to, even though, yes, I'm an endoscopic hemispherectomer. But when I'm in Africa, I'm a microscope hemispherectomer, right? It really depends on what I have and what I need to do.
Yeah, I was just going to say, I was going to comment as the non-surgeon, so I would say that, for the way I think of it is kind of much like my talk even, is it's ideologically driven, right? So the kids with the MCA infarcts are probably, they're going to do well. Those are the kids that actually will come off medicine, should be seizure-free, and, they're at default to the surgeon, whichever approach they're comfortable with, because they should do well no matter what, and they should be the easiest ones to disconnect. And in those kids, you don't usually have to worry about their insula because it's largely gone, right? As well. The kids that are the malformations, for years, we recorded from their insulas after the surgery, and they were always spiking away. So I agree with you, Dan. I think though the ones that we see that are the failures from elsewhere, it's because they didn't touch the insula and the malformations. So I think you have to think about the etiologies and the ones that are the big malformations that are just really hard for the surgeons because the anatomy is so screwed up. You may need to do a different surgery because the anatomy is so screwy, and we just don't see delayed supraphyseal stream or hemosiderosis in the modern era, and nobody's seen it. It's you look, you can't find publications, so it's really hard to find. Even the UCLA, they just published their 30-year follow-up, and with anatomic, they had none. So I think it's who knows why, if it's the shunning or what, but I don't know that should be a factor that goes into the decision. At the end of the day, the decision should be driven by what's going to be the best surgery, as you said, for the kid, knowing that the malformations, none of those kids come off meds. They go down on their meds, but if you look at the series, those kids are seizure-free on meds. Yeah. They're not quote-unquote cured. It's the MCAs that are cured. Yeah, so.
I think Mark's comment on monitored shunting is important to emphasize.
Right. No, I agree. The shunning, those
in
kids
this era, we just don't see a lot
so.
of the things that were described by the Rasmussen team in the Kramer paper, et cetera. And Sean Liu's paper looking at hydrocephalus post-hemispherectomy was shockingly close. Functional was 20%, anatomic was 30%.
Right.
That's not a huge difference.
Yeah.
So.
Amar, did you have a question?
I just have a question to the neurosurgeons about embolization. We've had one patient who underwent embolization as a substitute to hemispherectomy at another institution. They came back and they were not seizure-free. So I'm just curious what your thoughts are on that.
I've only seen that recently once, not personally, but in a presentation. So I thought it was really interesting, and now I have a follow-up that says it doesn't work. So
yeah, it's a good temporizer. So it's mainly done in hemimegalencephaly. It's gotten a lot of play in the hemispherectomy groups, the parents and the hemi-meg groups. And so that's hard to compete against. DC Children's is the main place that they throw a shingle out for that. And some of the websites are saying it's curative and they don't need another surgery. But I called Chima to see if that was true, and he's operated on a lot of them. So he said maybe 2 or 3 of them are still not needing it, but the concept is not necessarily that it's going to be curative. The concept is you get them to a weight that they can tolerate a big operation. So as a time saver and let the child grow, in good hands, it works fine. Downside to this, Chima mentioned, and I don't mean to quote him here, and he's not here to clarify my remarks, but it made sense when he told me this. The VEGF aspect of the baby makes the collateralization tremendous. So when you go in finally, it can be a bloodbath. So it does increase some of your surgical morbidity going to the final disconnection because of the strokes that you've induced and the collateralization that creates in a baby that's just a VEGF machine. But it does buy you time and allows you to do big operations on a bigger child and not in the NICU.
Maybe it's more trophic now too after that.
Yeah.
So,
I think we've got time for, we have 2 more minutes. Let me let Dave make a comment.
so very, very, very quick, and it's totally related. I was just going to ask about that. So, over the last 8 years now, I have, out of necessity, done 2 surgeries on a 4.1 kilo kid in the NICU and now a 4.2 kilo kid in the NICU. And both the one 8 years out and the most recent one have done amazingly well. So we usually wait, but from the neurosurgical point of view, with many of them doing so well, knowing the complications, with many kids having spasms and the neurodevelopmental outcomes, how long do you wait?
That's what I was going to comment on, is 4 to 5 kilograms is that's all we need, right?
Right.
So that's 2 months old usually. So it's you actually don't have to wait that long if you have an experienced team to take care of this, right? So yeah, I agree with you, Dan.
I definitely second that. The surgery on a 4 kilo kid at 7 or 8 weeks is very doable.
A little bit, it depends on the other hemisphere. I have one in the unit now, seasoned a great deal, and actually both hemispheres are screwy. It's kind of a TSC genetics kid too. So it's got this mTOR thing that's going on. Very confusing state. But we're probably going to pull the trigger at about 2 months.
Yeah. I'd like to invite everybody to take a break at this time. We are supposed to be back in here at 3:05. And I'd like to thank our speakers for a wonderful session.